I'm Zeke Emanuel. I work at the University of Pennsylvania. Used to be a practicing oncologist and now just yak about healthcare. With me to my immediate left is Elliott Fisher, who's a professor at Dartmouth and has done a number of the large studies examining variation in care across the country. And some of you may know it as the Dartmouth Atlas, and we'll probably end up talking a little bit about that. And further to his left is a fellow Coloradian, or however it's pronounced, a guy from Colorado who's now transplanted to Dartmouth. I guess the hills are a little different, but the atmosphere is the same. Gill Welch, Dr. Gill Welch, who is one of the great investigators looking at the tests, the efficacy of tests, the use of tests around the country, and in particular cancer tests. So we're going to talk for a few minutes about various tests, what we know about them, how they get used, and then we're going to open it up, 10 to 11 o'clock, something like that, to questions from the audience. So this morning, apropos of nothing, out of the blue, an old girlfriend emails me. Subject line, mammogram. I didn't make this up. It's 7:53 a.m. July 1st. That's today. What is your / current progressive medical thinking on them? I assume that refers to mammogram in the subject line. I've had one or two since 40. I have no history, parentheses, that I know of, though I have no family, so that's a hard one, of familial breast cancer. Thoughts on needing / getting? That's it. No signature either, so you guys can't know who it is. But out of the blue, and not an atypical question, I have to say that I get. I've actually, I think this is the second question in the last 7 days since I've been here that I've got the exact same question. And so it's a hot topic of, should women under 50 get mammograms? Gil.
Oh, I'm on. Hi, good morning. I'm happy to be back in Aspen, first time in 40 years. And before I answer that question, I just want to say I'm a conventionally trained clinician. I'm a believer in medical care. You may wonder about that in a little bit, but I think medical care can do a lot for sick and suffering people. I am worried about medical care moving out into the well population, looking hard for things to be wrong. Mammography is a perfect example of that kind of tension. And so I want to start by making sure everyone's clear of the distinction between a diagnostic mammogram on one hand and a screening mammogram. A diagnostic mammogram is when a woman recognizes a lump, becomes aware of a lump, goes to her doctor, and he or she orders a mammogram to find out whether that lump is worrisome or not. That's a good test. None of us debated that. Anything we say today is not about diagnostic mammography. The question is whether we should be inviting women in to look hard to see whether we can find abnormalities in their breasts. That's a very different question. Zeke, you're not going to be happy with me here. There's no right answer. Okay, I want to be clear.
You didn't go to medical school, obviously. There's always a right answer in medical school.
There's no right answer. It is a series of trade-offs
but you can't tell them
that patients need to understand. Right. I've characterized it in previous writing as a gamble. You know, mammography undoubtedly helps a few women, but it's a very few. It's a very few. And unfortunately, it harms others. I know it's always nerve-wracking to talk numbers a little bit, but it helps to have some perspective about how many people you have to screen to find the one person who you can help. And in mammography, in the age group of 50, if you screen them for about 10 years of annual mammograms, you might help 1 or 2 women. And my point is, it becomes relevant to think what happens to the other 998,
how many women?
999.
That's 1 or 2 out of 1,000.
Right.
1 or 2 out of 1,000, it helps.
Yeah. And in this country, and it's unconscionable, the rate at which we have false alarms, things that we worry women about, involves somewhere in the order of 300 to 700 women over a 10-year course of mammography. No European country would accept that. And then we have this additional problem that we label some women as having cancer when that cancer was ultimately never going to bother them. That's the problem of overdiagnosis. We don't know which women they are, but we know we end up treating more women for cancer because of mammography. There's no right answer. There's this gamble. You might be one of the few that's helped a great deal. You might be one of the many that are scared by the entire process. And I happen to think health is not simply a physical state of being, it's also a state of mind, and this can create a lot of unhealthiness in the population. And you might be one of the few who's treated unnecessarily and goes through the process for nothing.
So I want to ask you one other question,
yes, you may.
Gill, which is some women will go through a screening mammogram. There will be something which looks suspicious, whether it's a density or some collection of calcium. They'll get a biopsy and it'll be benign. Does that change their risk factors?
No, it probably doesn't change it changed their Gill risk factor model because we know women who get mammograms more often are more likely to have cancer found. And so, ironically, it becomes a self-reinforcing risk factor. But in fact, a normal mammogram in and of itself says something about your risk for the next year, but actually says almost nothing about your lifetime risk of breast cancer.
And after 50?
The one place I agree with the proponents, the strongest proponents of mammography, is there's really no magical age. Breast cancer risk increases fairly linearly with age. You know, the older you are, the more likely you are to get cancer. But it's nothing dramatic. There's no obvious place. I think the one thing we should say in general about screening is the people who stand to benefit the most are those that are at the highest risk. People who have the highest risk of cancer are the ones that are most likely to win the gamble I was talking about. But at average risk, I think in general, screening has this very poorly understood until recently sort of mixtures of effects that means that no matter how much money we have, it's still a real choice. It's not about the money. It's about how do you want to live life? How do you want to trade off these apples and oranges?
Okay, Elliott, we're going to switch from women to men. So several years ago,
I don't see a lot of older men in this audience. It looks like they're much more interested in mammography than. Although they might have a few partners who might be subject to getting some screening for prostate.
A few years ago,
cancer.
I went to a urologist, and before he was about to do his procedure, he had me in the office, and he said, "We're going to get a PSA on you." And I said, "Well, I don't want a PSA." And he said, "Oh, no, we're going to get a PSA." And I said, "Well, I'm an oncologist, and I know the data, and I really don't want a PSA. I don't think it's that helpful." And he said, "Oh, no, that's a population statistic. We're interested in you as an individual, and we want to get your PSA taken because we want to be sure that you won't get cancer." And I said, no, I really don't want that PSA. And as many of you know, I'm not exactly a wallflower. We had an argument for about 10 minutes. And then it dawned on me, I'm also not that smart, so it dawned on me, he's about to operate on me, and maybe it's not a good idea to make him mad at me at just this moment. He is a urologist after all. So I shut up and I went into the exam room. Do you think I got the PSA? Yes. Absolutely yes. And then he called me about 5 days later and he said, "Dr. Emanuel, your result." And I said, "Listen, you got the PSA for yourself, not for me. Click." Was I right or wrong, Elliott?
Well, at least you made the choice, Zeke.
No, I didn't make the choice. I got the PSA. Someone got that result.
But at least in the end, you made the decision about whether you wanted to know your PSA risk. So it's a very analogous situation where lots of men have prostate cancer, and if you look hard enough, you'll find it. The numbers go up dramatically as we age, so that it's a majority of men over 60 who've got prostate cancer. And a slight abnormality of the PSA, an elevated PSA, might lead a urologist to say, gee, we better do the biopsy on your prostate. And then you might well find prostate cancer. The difference between prostate cancer and breast cancer is I think the benefits are similar of potential life extension for a very tiny fraction of men who have a detected prostate cancer from the recent trials. There probably some small benefit. But the treatments that men undergo, if they're faced with the choice about treating prostate cancer, are probably quite a bit more harmful and have more side effects. If you take the recent Pivot trial, which looked at, so I'm a man, I've drawn the wrong straw, I've got prostate cancer, so I decide to undergo radical prostatectomy, which is probably the most effective of the treatments. So 4 out of 5 men who do that will have sexual dysfunction after the surgery. 1 out of 5, 17%, will have significant enough incontinence that they'll either want to wear a bag or wear pads, and it'll be significantly bothersome symptoms of incontinence. So again, it's a choice, and I think that's where on these screening issues we really have to come down, because it's, shoot, so I actually personally feel quite similarly to Zeke. Do I want to know this? And you'll have to figure that out for yourselves or advise your partners about how they'd feel. Because I actually still enjoy sex, and I'm not anxious to wear a bag. But
aren't you afraid of cancer?
Actually, not terribly. I mean, lots of people die. It's the second leading cause of death. I think it's how many of us will make our way out of here. If I actually look at the experience that many patients have with cancer, it's unpleasant, but they get to be with their families. They get much more effective planning around end-of-life care than many of people who have heart disease or strokes or other causes of the way we exit. The one thing epidemiologists know for sure is that we have a 100% mortality rate. Everyone dies.
Not in America.
It's the only thing we know for sure. So I think it's quite analogous. A huge reservoir of disease that we can look hard to find. Screening tests that will detect it, that can't tell good stuff from bad stuff, and tough decisions. Actually, I don't think that decision's that hard. I think it's oversold.
So why was my urologist so insistent, do you think? Not knowing him, but.
We have the culture. I mean, I think some of this comes back to medical culture. I think physicians are trained to think that the way you take care of people is find stuff, treat it, intervene early if possible. And that he's doing you a favor by finding your prostate cancer. He doesn't see the downstream side effects as frequently as the men will experience them. And so I think that we as patients sitting in this room all think, God, I want to live forever. I think those of you, how many of you read the New York Times piece this morning about treatment of labor and delivery and the high cost of labor and delivery? But patients are calling for all of this early testing. A lot of the physicians were arguing that this is the patients are saying, I got to get an ultrasound. I want more ultrasound. So part of this is patients driving this. His other patients are all demanding it. Some of it may be medical legal stuff, but I think that's an excuse largely. I think it's mostly the sense that we got to find it early and we got to intervene that drives American medical culture.
And we've been promoting this for years. I mean, we can now blame patients. That's fine.
Right.
All right, it's all your fault. But the profession really did promote, and we aggressively promoted mammography. We offered free PSA testing. So we have some ownership as well as a profession and as an industry of making it sound so simple. Of course you want to look for early forms of disease. Of course. Why wouldn't you? And of course, most people would look at that and say, yeah, there's all upside, there's no downside. Until you begin to think a little bit more carefully about the problem and you realize that we all harbor abnormalities. Our technologies are increasingly able to find them. And when physicians can't sort which abnormalities are important and which aren't, our default is to act, to treat. And all of our treatments have some harms. Some more than others, but they all have some harms.
All right, well, here's the next one.
All right, next question, Zeke. Here it comes.
Well, next test.
All right,
we're moving
next
to
test.
All right, so a few weeks ago, I did voluntarily, that was the surprise, got a colonoscopy. Was I stupid or smart? All right, was the colonoscopy appropriate or not? Let's make it a little easier.
Right. I'll say, so my focus has been on the problem of overdiagnosis of cancer. And just so everyone knows, this is finding cancers, something that meets the pathologic definition of cancer, but will ultimately never appear clinically in the patient, will never bother the patient, will never cause death. Colon cancer screening is not associated with the overdiagnosis of cancer, particularly. We're seeing cancer incidence fall in colon cancer. It's probably been falling predating any of our interventions on it. It's just since the 1985, we've had less colon cancer. That's good. Maybe our diets are better and so forth. So I am less worried about colon cancer screening leading to a lot of extra treatment. It seems like the main thing that the gastroenterologists find on your colonoscopy is that you need another one. I'm worried about that.
Yeah, another New York Times article a few weeks ago that many of you may have seen. Colon frequency but no, not just the expense, but doctors saying, "Oh, I didn't quite see the last 2 centimeters of your colon. You better get one in 5 years." And the incentives, they're paid huge amounts for this procedure. It's done by other people elsewhere, and so the current incentives align gastroenterologists to say, "Zeke, we didn't quite see far enough up. You better come back next year."
I will say, no, she said she saw far enough up, but she did say, I did see a 3 millimeter Ditzel, and you should come back in 5 instead of 10 years.
No evidence for that I'm aware of.
Right, so you would recommend every 10?
Until 75. I think that's what the gastroenterologist
Let's be clear what the U.S.
Yes.
Preventive Services Task Force says. We've got a number of ways to screen for colon cancer. The way we've actually tested well is the fecal occult blood test. It is simple, it is easy, it's done at home, and it's actually done more regularly than a colonoscopy. We are in the process of studying, in the biggest randomized trial going on right now in the country, the question of whether fecal occult blood, the simple annual test, how it compares with colonoscopy. The not simple, go to almost an operating room situation with anesthesia and so forth to try to see whether there's any difference between these two. And by the way, colonoscopy is not perfect. It clearly misses lesions. And by the way, no screening test is perfect. One of the things we should be clear that just because you're screened doesn't mean you're not going to die from cancer.
Or that particular cancer you're trying to find.
You're not, and ironically, the very worst cancers, they're the ones we tend to miss.
Right.
And so when are we going to get the results of this trial, whether we should do fecal?
Yeah, unfortunately, it's going to be, thank you for that question, Zeke.
It's going to be a few years.
I know when I'm on Social Security is what I think.
It's a decade.
Yeah.
And by the way, that's another thing you need to know, is our information base for this kind of work is never going to be that good.
Why?
Because you have to involve thousands and thousands of people to see an effect. That tells you something. The effect is small. Right?
Yeah,
we learned the value of treating high blood pressure in 150 men treated for a year and a half. It was dramatic. It was huge. Screening has to involve thousands of people to determine over usually a decade to try to get a sense of the effect. That tells me something right up front. We're looking for very, very tiny effects.
Yeah, to get a sense for breast cancer, the estimates in the 40s, who knows how good they are, but the estimates of benefit compared to, you get a 5-day gain in life expectancy. It's about comparable to riding your bike without a helmet or with a helmet for 15 hours with or without a helmet. 2 ounces of body weight gained is about as much risk as failing to get your mammograms in the 40s. So that the benefits of these interventions for healthy people are tiny compared to the other kinds of things we could do to improve our health. Stopping smoking if you're a smoker, 3 years of life expectancy gain compared to days for these. So start thinking about the numbers carefully and saying, well, what could if I'm really worried about improving my health, I might walk back to the hotel and probably get as much benefit as I would from screening.
All right, one more test, my annual physical. So I recently got an email suggesting from my doctor that I should come in for my annual physical. So I'm debating whether to do it. I will say that a good colleague of mine, a boss of mine once told me that he for many decades did not get an annual physical, but he got term life insurance every time so that they would come and get his blood test. He thought that was the only benefit of his annual physical. So he just got
What's
his.
the benefit of the blood test?
He was head of OMB, wanted to see what the results were, but he thought the blood tests were more valuable than the doctor taking his history and poking around, and so that was a cheaper way of getting his blood test since he didn't have to pay for it. The insurance company was paying for it. So
This guy's cheap.
that we know. But the real question is, do we get the annual physical or not? And what's the view of that? And especially, I presume many people in Aspen get the $10,000 executive annual physical. Is there any evidence that's worth anything?
Well, it's worth a lot for the people that deliver it.
I guess it's all your perspective, Gill.
But Zeke, before I answer that question, what will you do?
Oh, no, you answer. I'll tell you what I am actually with my boss, which is I don't think the annual physical, my review of the literature is I don't think the annual physical is worth it. In part, I'm asking you the question because a very respected leader in American healthcare, a guy named Hal Sachs, recently wrote an editorial poo-pooing all the studies, there are about 48 or 49, maybe you know more, suggesting there's not actually all that much in the sort of random annual physical if you're feeling fine. And he said, well, those were old studies, and maybe, with the new technology, new personalized medicine, blah, 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 maybe we should do it. So I'm asking you guys, what do I know?
Well, I think first the literature, such that it is, and it's not good, it's not great, it was back in the 60s, 70s, didn't find any effect to the annual physical. And of course, when we talk about the annual physical, we ought to mean, well, what is it? And of course, it's so many different things. It could be batteries of tests, it could be palpations, it could be listening to your heart. I wish we could get out of this sort of mindset that we had a check-up with our doctor. As a doctor now, I'm coming back to this conventionally trained physician. I do like the notion of a check-in, just how are you doing? Just some sense of what your symptoms are, what your life stressors are, what your relationships are like, how your job is, how I can get a sense of where you are at and what your preferences towards healthcare are, how you feel about end of life. That kind of relationship I would like to preserve. What I don't want this check-in to be this exhaustive search to try to find something wrong. I don't think that's a path to a healthy society. I don't think that's in our interest to be aggressively looking for things to be wrong in people. Because the truth is, we will always find something. We can always find something.
And shouldn't we know, though, Gill, yes, we can always find something. Don't we want to know we can find something so we can intervene?
The problem is that since we all harbor abnormalities, that's a recipe for everyone on medications, everyone getting operated on, and that's not going to be good for our health.
Why not?
We can't sort out which abnormalities are important and which ones are not. And by the way, but that's at the level of when people are well. It is hard to make well people better, right? It's hard to take a well person, make them better. It's not.
You know what I do with my students who have their cell phone go off in class? I'm notorious for sending them out of the room.
I'm going to protect you from it. But people who have symptoms, that's a totally different route. That's the people we can investigate and figure out what's going on. The question about how hard to look for things wrong before people have symptoms is a very different
So since most
question.
Aspenites are in really good health, you don't recommend a lot of mucking about?
No, I absolutely don't. But I'd like them to have a connection with the system.
Yeah, and there's a lot.
And check their blood pressure.
Yeah,
I'd like to have
knowing that your blood pressure is okay. Knowing that you're not smoking, knowing that you're not depressed. I mean, there's a lot of occult depression. Screening for depression is probably, among a group that it's one of those screening tests that probably is worth doing.
Although that's why we have so many people on antidepressants, which is
absolutely
another issue.
Problem. But they're also, so there are benefits, especially the relationship, but there's no benefit of the intervention. I mean, the example of intervening for stuff that doesn't, that looking for stuff 50% of people have abnormalities on their MRIs of their backs that an orthopedic surgeon could easily decide warrants some intervention. We're not far from Casper, Wyoming, the country's capital of back surgery, tenfold greater than the back surgery rates found in Lebanon, New Hampshire, where we're from, or La Crosse, Wisconsin. There are probably a few orthopedic surgeons up there who, anytime somebody goes through town and has the slightest bit of back pain, will find something and then recommend something. So it's really important to, at least think about looking for stuff carefully, based on evidence when you have real symptoms. But even when you have symptoms, if 50% of 50% of adults have back problems on their MRIs, all of us, 80% of us have back pain at some point. The question of whether intervening in the setting of an abnormality found on a scan, you ought to really think carefully about.
So this brings me to one other test, and then we'll soon open it up to everyone, which is Alzheimer's. You can't remember, right? We're going to have a panel about that tomorrow, but I just wanted to, so there's one test at the moment, ApoE, which is used. Is that something, and now there's also, I guess, imaging that you can use.
PET scans.
Yeah, PET scans.
There you go.
What about those tests?
Like I need a functional MRI to know that I can't remember anything. Hello? What's happened to our business? Like we need a picture to know whether we can remember something or not.
What's happened to our business? It's a business.
I think one of the things that is really important about tests in general, no test helps anybody by itself. Right? You've got to have something that you can do about it, right? And Alzheimer's disease, unless you're going to have some infectious disease control issue, so I'm not talking about infectious diseases. But here is a case where, hey, we don't really have a good intervention. Why would we be sorting around looking for early forms of this? Well, you have nothing to do except scare people. And by the way, your information isn't that accurate anyway. So I think this is where we need some just common sense. Like we shouldn't be testing for things that we don't even have a good idea what we would do differently. That's just totally non-productive. And yet I happen to think that part of health is about people's state of minds. And we shouldn't take lightly upsetting them.
The evidence on what labeling does to people is real. The data is, the studies are old, but you give the studies from Seattle of kids given by their pediatricians a diagnosis of heart troubles because they heard something through the stethoscope. Yeah. There are 100 kids, only 2 of them when followed up had anything that was anywhere near serious and of course didn't require any intervention. But a bunch of the other kids had been taken out of school, held back. They were labeled by their parents as having heart troubles. They
didn't exercise.
They were told not to be in sports. So that the harms of being, how do you feel about yourself when? Now, of course, on the cancer side, I'm a little, if 30% of the women who have cancer are, overdiagnosed, as Gill suggests, and feel great as cancer survivors, I've got to say. So there's a positive. They're all wearing. There are some. It's really complicated. But we have to be really skeptical. I mean, how many CEOs do we have, or partners of CEO? I mean, who would make a major investment, spend a whole bunch of money to buy a new company without looking at the data? And yet, what are we doing in healthcare? Trust the doctor.
So, my last question before we get to the audience is, Elliott, you are arguably the country, maybe world's leading expert on variations in care. How much variation is there? You mentioned the back surgery. And, can we isolate situations where we're getting a lot and it's valuable from where we're getting a lot and it's not valuable? And what can we do about the situations where it's not valuable?
Well, the evidence on the magnitude of variations is pretty remarkable. So whatever we look at in terms of major surgical procedures or diagnostic tests, the variations across communities that are pretty demographically similar or you can adjust for them. So we see 5-fold differences on average in the rates of surgery across the 300 regions we define. So whether it's back surgery, knee replacement, hip replacement, cardiovascular surgery, interventions for stents for asymptomatic disease. It's about a 5-fold difference. No evidence that the places with the higher rates have better outcomes. They're certainly getting treated more and they're spending more there. And
there's not any one particular area where people actually do better because there's more treatment?
On the population base, we've looked at it in a couple of different ways. If you look at U.S. regions and you compare them and group them in 5 groups and look at, and this is moving to spending. So if you spend 60% more in a population of Americans covered under Medicare, there's no evidence of benefit, and there's probably some evidence that the quality of care is worse just because of the fragmented nature of the care in places that are dominated by a lot of specialists. So we did the same thing looking at academic medical centers. So you can go to the panel at about Sinai tomorrow, compare it to Scott and White in Texas. Spending difference is probably a factor of 2. No evidence that you're getting better care from the place that spends more. Most of the differences are due to overutilization. So it'll be the unnecessary tests, spending more time in the hospital, getting to talk to more different specialists. And there's no evidence that that kind of additional discretionary treatment offers much benefit. Actually, there's no evidence that offers any benefit. And so you're wasting a lot of money and probably spending a lot of time in docs' offices that you wouldn't need to spend otherwise.
So what, as a patient, not as an expert, what would you recommend to most people have arguments with their urologist as they're about to be operated on?
I'd be looking, this is a moment where healthcare is shifting pretty radically. We're moving from a healthcare system that's always paid on the basis of volume, where the only incentives are to do more and to do more expensive stuff. And there are now emerging places where the incentives are starting to change, where the movement is toward systems being rewarded for improving your care. And I'd be asking, if I were a consumer, I'd be asking skeptical questions about, so how are you paid? What's the system within which you're working? How much support are you getting for improving care? Do you have quality measures that you're being measured on? I think we're going to have to get out of the mess we're in. You need to shift to systems where the incentives are better aligned. You just can't read this morning's Times or the one 2 weeks ago about colonoscopies or look at the practice patterns in McAllen, Texas, and say fee-for-service medicine is a formula for great care. But I'd mostly be skeptical of your doctor.
Yeah, I just want to add one thing that I think is always hard for us doctors to hear, but I think is really true. It's sort of the thing we would have learned the first year we went to School of Public Health, and that is that medical care itself is a relatively weak determinant of health. At the population level, it's not that powerful. It's much more about how healthy the population is, whether it exercises, whether its diet is, whether it's employed, the income levels. Medical care in itself can do a lot for select individuals under selected circumstances, but that throwing it at a large population willy-nilly probably is actually not good. And so what I think you need to look for in the system is for someone who can kind of shepherd you through the system. And I'd like to think that'll be a primary care practitioner, but then again, I am a primary care practitioner. But someone who is really giving you advice in both directions, who's not hesitant to say, I don't think that's actually in your interest pursuing that kind of level of care. Someone that understands the trade-offs, and I think that's the kind of model. The old word was a gatekeeper. What a horrible kind of concept. But what you really want is someone that can shepherd you through the system.
Okay, we've got a microphone here. Someone will bring No, sit in your seat.
Yeah,
Richard Besser, you sit in your seat.
You have a microphone all the time. You can't have one today.
So we're going to have some questions back there. Yes, you won the card. Stand up and tell us who you are.
My name is Nancy Dunlap, and I'm from Houston, Texas, and Aspen, Colorado. We do a lot of medical testing in Houston, Texas.
Yeah. Oh, yeah.
But we've had a lot of conversations here about genomic medicine. So that's going to be coming at this from the other direction, and maybe you can both comment as to how soon we can converge and maybe get the benefit of one and reduce the other.
Great question.
Yeah.
You obviously were not here last year at the argument Eric Topol and I had about this.
Yeah, I suspect you said the same thing I'm about to say. I think we've totally overpromised the value of genetic information. I think we've exaggerated how useful that will be. By the way, I want to distinguish that from genetic testing of cancers, which may be a nice way to sort out which is going to be responsive to which treatments. That's a totally different. I'm talking about scanning our own genomes, trying to suggest to 20-year-olds what their future risks are. I think that's but by the way, to really know whether that's helping, you thought finding out whether screening helps, or finding out whether that helps is like 40 years of data collection on literally tens of thousands of people. So I think that promise has been vastly overstated, and I think people think that the genome is something perfectly predictive, and most of it is certainly not. Genes are not 100% penetrated. If you have this, you know you're going to get that. We're going to find a lot of weak relationships, and that's what we're finding.
And in fact, when you look backwards from people who are sick to go find a genetic marker, you're way exaggerating the potential benefits because you've started with a pool of people who are sick. I agree with Gill.
Man in the green shirt there.
I'm Curt Malkoff. I'm a PhD psychologist, and I'm fascinated by how people receive medical information. I guess the two classic books are Jerry Groopman and his wife, How Physicians Think, How Patients Think. And Zeke, I'll put you on the spot.
That's fine.
I was somewhat fascinated by your response to the urologist saying, okay, I'm going to get your PSA. I don't want to see the findings. Speak to that just a little bit. Why not?
Well, I assumed that he didn't harass me, that they were okay. But I also didn't want to have a situation where they were 4, which is the break point, and then do I get follow-up? Do I not get follow-up? I don't want that uncertainty. So what I've learned, I was trained as an oncologist and treated a lot of people for breast cancer mainly, and what you learn is it's actually not the diagnosis of cancer which really kills people. It is the uncertainty. When they're sitting waiting for the scan, or when they're sitting, is this thing really coming back or not coming back? That's what drives them nuts. And I didn't want that. So I would rather not know. I assume that at some point, if I live long enough, but I won't live that long.
But not knowing is an uncertainty.
No, it's not an uncertainty. I put it out of my completely out of
an uncertainty.
Lots of men are going to end up with a PSA between 3.5 and 4.5, just at the break point, and then there's going to be constantly worrying. Well, did I make the wrong choice?
The break point's totally artificial. Right? I mean, some urologists are arguing for 2.5, and some are going with velocities. The problem is, and this is why it's a choice. I thought, I spent a lot of time studying PSA, and part of me said, oh, I could do so much better. I could use a higher threshold. Maybe I should do it, and then I realized, wow, you're spending your whole life worrying about this and wondering whether you're doing the right thing.
Yeah. We've got a question in the back here.
I'm Herb Newman from Akron, Ohio. And I think I'm just going to shoot myself now, having heard all this. So I'm your typical consumer. I finished my colonoscopy and went for my annual physical. And here's a node in my groin or a bubble or something, CAT scan. Took the CAT scan. Go back to see the doctor, and it's not just that, vascular somebody. You also have a thickening of the wall in your bladder. Some calcification. I says, well, what the hell is that? Well, we're all calcifying, but it's here and there. I says, stop. I said, I'm going to take a picture of this report with my smartphone and screw it. I don't want to hear anymore because I know I'm protected because only the good die young and I'm safe. But, all right, now we have all these genes. So now what the hell do I do? Somebody told me that not only do I have this bubble here, see vascular whoever, and by the way, I go to the clinic, which is a bonus because they don't get paid to cut. And whenever I have a real problem, in my mind, I go to the clinic because they say, you're too old to be cut, go home. which is a bonus. But now what do? I have a thickening of the wall of my bladder. I says, well, what the hell is that about? He says, well, we ought to make sure you don't have cancer of the bladder. I says, oh, shit, what do you mean cancer of the bladder? I came in for a bubble in my groin. And now I'm dying of cancer of the bladder. I took a colonoscopy. They've got some nodes. I'm going goddamn crazy here. So now when somebody says to me, you ought to get a urologist for the thickening of the wall of your bladder, now what do I do?
All right, well, I'm going to answer, and then I'm turning it over to Elliott. I'm going to give you my, so I have a brother.
I'm not going to die.
I have a brother who, as I like to say, has too much money for his own good and is a bit of a hypochondriac. And about a year and a half ago, he calls me up, and I don't respond to the first call, and he urgently, you know that it's serious, so I pick up the phone, and he says, I got one of those CTs of the heart, and I got 2 calcifications. What do I do? And I say, schmuck, you call me after the test? You're supposed to call me before the test. I'm going to tell you that's an idiot test to do. And that's part of the problem here, which is you are stuck with, way too many tests, and we have no idea what thickening of the blood, at least that would be forget the urologist. But Elliott may have a very different view of this.
The last thing you want to do is have me practice medicine without seeing this, but I think Zeke's covered the key question of after the test. I mean, and we're the coronary calcifications. If you look at how patients misinterpret the data that they've got, the best example I know is this elective coronary artery stenting for asymptomatic patients. You interview patients. There's no evidence from the trials that intervention for asymptomatic coronary artery disease causes any benefit whatsoever. But if you talk to patients after they've had their stents placed, 80% of them think they've had their life prolonged. So they're making decisions in a setting of overconfidence that they're getting benefits from the interventions. And again, it comes back to this skepticism. Interestingly, the same study showed that 50% of docs would recommend a stent even if they knew there was no benefit from it.
Up here. Yes. No. Oh, well, okay. Then this woman right behind.
Bruce Bodakin from San Francisco. This is very interesting. You haven't mentioned family history as making any difference as to whether you ought to get a diagnostic test. And in that regard, I think it'd be interesting to hear your view on the Angela Jolie situation of getting a genetic biomarker and then going forward with a relatively radical.
I was going to ask that question.
A relatively radical intervention, and knowing we're all men and sexist. But.
Gill.
Well, Angelina Jolie. Yeah. Okay. I always get to talk about Angelina, who I don't know. Again, the general principle holds that the higher the risk, the more likely screening. We're talking about screening, not diagnosis. We're looking that a screening test is more likely. You're more likely to be a winner than a loser if you have a really high risk. There's not that many things that put you at really high risk. The strongest evidence we have where it actually changes life expectancy, which we really don't, overall, all-cause mortality, is not in breast cancer. We don't know that. It's not in prostate cancer. We don't know that. It's in lung cancer in smokers. Why? 20-fold risk increase. That's a huge, of dying. That's a huge bump. And even there, screening's a close call. We can demonstrate it probably that it lowers all-cause mortality, and yet it's a close call because there's a lot of extra biopsies, you drop lungs, there's overdiagnosis, there's extra treatment, and it's a choice. Angelina Jolie is in one of those really high risks there, and I was saying most genetic information isn't very powerful. BRCA1, it's powerful. So she made a choice. She made a perfectly rational choice. I'm not saying it's the only choice, but it was a perfectly rational choice.
Okay. Wait. I promised this woman here. No, this woman right there.
Hi.
Stand up.
Oh, God.
Tell us who you are.
I'm Susan Engel. So a year ago, I had my annual, and the doctor told me that my cholesterol count was too high, and that I better start giving up sweets and giving up butter, and that very soon I might have to go on medication. Well, I'm a researcher.
Take the phone. Take his phone. Give me that
They
phone.
want to know whether to get the statin, to be on the statin. It's probably my brother. It's my brother.
Absolutely.
So I'm a researcher, but I'm not a medical researcher. And I thought, I'm not that fat. I have no history of heart disease in my family. Really, what's the evidence that lowering it artificially, either through diet, well, that's artificial, diet or the other thing, medicine.
Statins, yeah.
would protect me in any way. So I went home and I started reading the research, and I couldn't find any compelling experimental evidence that lowering it in the absence of the other factors.
Now we're getting to controversy. All right.
Okay, so, but I have one piece is I want to know the answer, and the second piece has to do with your point about what patients should say to doctors, because it's fine for you to say, no, I'm hanging up. And I said, I don't care, I'm still going to eat butter and dessert. But how do people talk to their doctors?
Before
when
we
they
answer
know
that
something?
question, I want to ask you just three simple things. You have
yeah.
normal blood pressure?
Yes, low.
Right. Heart rate is okay?
Good, yep.
Yeah. And you exercise regularly?
Yeah.
All right.
Any family history?
None. That's why
She
I
said that
started
already.
reading the
Gill,
research.
you weren't listening. Well, your phone was going off. All right, Gill, what's your answer here? Now we're going to get controversy. This is actually a useful one.
And what is your cholesterol?
Oh, I forget, but it's...
Let's assume it's 210.
But okay,
210. I'm giving you the
next case.
No, I disagree.
Next case. Next
Here's where we
case.
disagree.
You're putting on a statin?
I'm putting her on a statin, and I'll tell you why. Not for your heart disease, actually. You will lower your cholesterol on the statin, but statin has lots of other benefits, which you see, he's not discounting. Right. So this is where
but there's debate. There certainly could be some.
I'm in the same category you are, 210. I went into my doctor and I said, I want to be put on a statin. And he runs out of the room. This is a good primary care doctor. And he actually prints out the recommendations on cardiac disease. And I said, that's great. That's cardiac disease. The advantage of statins, right, extend well beyond cardiac disease probably. Plus, if I lower my cholesterol, that's fine. I view actually a statin. They do have some side effects. We should be clear, muscle problems mainly.
But Zeke, you're not treating the cholesterol. You're just doing it the way we would used to do an aspirin. You would say, no matter what my cholesterol is, I should be on a statin. That's a different thing, right? You're arguing like we do for aspirin.
Right. And I also think you should be. Aspirin's the greatest drug ever invented, in my opinion. But we're going to discuss that with Dr. Besser in about an hour, right?
Yeah,
50 minutes. So. Oh, because it probably has other benefits in terms of risk factors for Alzheimer's and other things. So I think given a close call, and it is a close call, and my primary care doctor was outraged, and also given the fact that it's cheap. So there are lots of them which are generic now. I figured, for $5 a month, and it doesn't cause muscle issues with me, might as well do it. It may help with the cholesterol, and that probably won't change much. My heart rate's about 40, and the blood pressure is relatively low, unless people talk to me about healthcare reform. And then, and I figure what the other benefits which are likely to be shown, you might as well do it. But I am definitely in a minority wacko community. I think Gill is much more in the normal,
which is not.
All right. Lifetime.
I wouldn't.
He says he wouldn't. He said he
I wouldn't.
All right, we're going to go in the back there, the guy with the hat.
I wouldn't either. There is a separate issue that's been raised here, which is, and it's the research is really pretty terrifying, and it's exactly what Zeke experienced. That patients are very scared about even having these conversations, even about sharing a decision making with their physician. So that we have trained a bunch of patients to be scared that they're going to get bad care if they question their physicians, and we've probably trained a bunch of physicians to be threatened by consumers or patients who ask them important questions. And I think one of the most important transformations we have to make in American medicine is empowering patients to feel comfortable saying, I need to engage with a physician. If you're not a physician who wants to engage with me in conversation, you're not my doctor. I think Gill's point about having a good coach, a navigator who you trust, who can help you through these complicated decisions. And probably the best test, best diagnostic test, although I have no evidence for it, of a good physician is one who would be happy to have you have a second opinion. Who would, of course, welcome you to go see someone else to help you understand it better.
All right.
Hi, this is really fascinating.
Tell us who you are.
Huh?
Tell
My
us.
name's Joel Kipnis. I'm from New York. I have a two-part question. The first thing is screening, and the second one is protocol. So in terms of screening, my father was in the best shape you could ever be, and he died at 40 of melanoma. And he went to the doctor never asked to see his skin, to look at him anywhere, had no idea that he had melanoma. And as a result, he died extremely young. I've now outlived him by 11 years, got screened, and it saved my life like 4 times. So where does that fall in the scope, and why is there no protocol?
Screening for melanoma.
Well, like if you go to a regular doctor, how come they're not asking you those questions?
Look at your
Because
skin, at least.
chances are you're not going to go to a high-end Park Avenue guy and say, hey, check me out for this. So why is there no protocol in the medical community to check? Because what you guys are saying is so fascinating. Why are we not checking for the things that could really, really benefit? And I think they're a little vaster than just lung cancer.
Well, I'll say one word about why I think the melanoma screening is not done particularly well, which is if you look at the medical training, and I'm not uncharacteristic, I don't recall actually an hour in medical school about skin exams. We did have a lot of stuff where they showed up, this lesion, and they, of course, take the most horrible looking lesions, which are easy for any moron to see because, they got wiggles all over. But the complicated ones, we're just not good at it, and we don't get a lot of training in it. And then dermatologists, of course, are very busy fixing noses and other things, and so
they're very busy following pigmented lesions right now, Zeke. This is another epidemic. This is a very complicated area. We have actually no evidence that melanoma screening helps people. I wish I could tell you otherwise. And this is first. I'm sorry about your dad, and even if
I've been screened,
yeah.
and on 6 occasions it stopped me from dying. So.
Well, I don't want to disabuse you of that notion, but I'm sorry, that doesn't mean that, in fact, those melanomas were going to kill you. Let me tell you the big picture, this view from space right now, is melanoma incidence, the rate of new cases is up 3-fold as dermatologists and primary care practitioners are doing more and more punch biopsies. We're finding all sorts of melanomas. By the way, a lot of deadly melanomas aren't in the skin. They're on other epidermal surfaces. They're in the mouth. They're in the rectum. So it's not like melanoma skin screening necessarily will even get all the deadly ones. And the death rate for mortality, the death rate for melanoma has been totally stable or relatively stable over the last 30 years, despite the fact we're finding all these more additional melanomas. It's a tough one to know what the right thing to do is. Everyone has, it's this belief that looking hard for things to be wrong will ultimately help, when in fact some of the worst cancers happen very quickly in places that may not, in melanoma, that it may not even be visible to the human eye. It's the tough world of trying to get ahead of things. You end up finding a lot of things that may not matter.
Hi, I'm Tim Andrews. I'm a bit of a ringer here because I work in healthcare, but actually I'm a type 1 diabetic for 35 years, which is my question here. In keeping up with technology, so there's been a lot of talk about don't do everything to everybody, so there's a secondary question here, but the primary question is, how do you keep up with technology even at the rate that we discovered? And the thing that kills me is, like, my primary care guy is calling me up every week now and saying, you need to come in and visit me because he's on a pay-for-performance program that says if I don't get an A1C 3 times a year, he gets punished, right? I have a continuous glucose monitor. I test my blood 12 times a day. We know what my A1C is going to be, right? And my primary diabetes guy at Joselyn says, you don't have to see me 6 months, 8 months, unless you're feeling some problems, right? So how do we resolve this problem that technology advances, and as patients actually do, in theory, the right thing and begin to take over their own care, a lot of the excess care is already in the system, and people are punished if they don't do it because it's seen as a quality measure. The secondary issue is...
Wait, the one's enough.
Okay.
All right, we got
That's
a lot
a
of
great
people
question.
It's a great question. We need the challenges that we're imposing on the healthcare system by using the quality measures that we now have create the kinds of problems that you're experiencing. But they're probably better than nothing. That is, it would be better to have people taking good care of diabetics than not taking good care of diabetics. And it's one of those things where, as you start to say, how do we make this thing better over the next 5 years, making sure we take pretty good care of diabetics, but not aim for hemoglobin A1Cs of less than 7, where we're going to kill people. Getting those targets to be reasonable, figuring out how you allow patients to report their data. I mean, the really dumb stuff is insurance companies can't even communicate information from one insurance company to another insurance company, so that patients are being called in when they've had the measures just because they change plans and they don't know that there's a lot of dumb stuff that's happening and you're experiencing it.
Right up here.
So my question was about, I'm Joselyn Wyatt from San Francisco. My question was about annual pap smears in your 30s. Necessary?
Annual?
Yeah, it should never be annual now. But
Well, this is an example, by the way, where recommendations are actually beginning to get more conservative. And that's where I feel like there's some real hope in the system, that people realize that doing things too frequently.
why don't you give the U.S. Preventive Services?
I'm not sure I can. Why don't you?
So I think it's after 3 normals, you can go every 3 years. Is that right?
No. I think it's now every 3 years. Every 3 years period.
Okay.
And after a bunch of normal.
In your 30s, necessary or not necessary?
No.
No.
And with an HPV, it could be every 5
Yeah,
Yeah,
with the
Negative
vaccine.
HPV?
Yeah, with an HPV vaccine.
testing of HPV as an
right.
alternative to the vaccine.
It's evolving
Okay.
rapidly.
We're going to go over here.
A waving hand.
Yeah, this lady can't control herself.
Yeah, well, let's
Let her enter the microphone.
They want to. Others will want to hear.
Hi, Julie Hill. How do you feel about the AMA's decision to label obesity a disease and the screening for obesity for the BMI?
Well, first of all, on the BMI, we know that that's a imperfect measure, but it's as good as we got at the moment. And it depends what you think the importance of labeling something as a disease is. It's clearly, if you look at what the word disease means, it clearly falls within the category of a disease, which is an abnormality that's going to cause impairment of your normal bodily functions, and that's definitely true about obesity. The question is, it's a much more political economic decision. The issue is, if you label it a disease, insurance companies are then going to be forced to cover it, yada, 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 and then a lot of the interventions that people have suggested, whether it's banding or whatever, are suddenly you're going to have a different attitude in the payment. So I do think if you look at what we mean by disease, it's clearly a disease. I think if the question is, ought insurance companies pay for various things, that's a secondary question. I do think it does suggest a important change of the American society's attitude over the last 4 or 5 years, really since the First Lady's initiative towards obesity. I mean, we've just had a very, very dramatic shift in our view about eating, exercise, obesity, all the processed foods products. And, I think to the extent that it adds to that social shift and the willingness of society to take on the whole issue is probably a good thing. So we have time for one last question. I guess you're holding the mic already. I can't even call on anyone.
That was pretty
Usurping
smooth,
my
huh?
role. All right. Last question.
Okay, my last question kind of goes back to this lady's question about her cholesterol level and the fact that most medical training only includes about 24 hours of nutrition or 25 or something in all of your years of medical
25 hours
school.
of nutrition?
I don't think I had 25 seconds.
Did you even get that?
I didn't have 25 minutes.
25 minutes. And so, related to this question about obesity being a disease and cholesterol levels and prescribing a statin without actually going through, really prescribing nutritional intervention and then following that up, and maybe putting some sort of, follow-up after 3 months or something, because, what I've seen thus far is with the statins that,
All right, well,
people
let's deal with the medical school, the nutrition question, since we're already over time and they're going to kill me because I need the room.
Thank you.
I have nothing to say.
You have nothing to say
Well,
about
okay, I mean, all right.
Yeah,
All right. Well, first, I agree. I'm very sympathetic. I mean, the question isn't this a very important part of health? Yes, it absolutely is. We haven't quite figured out what the best way, whether the first lady can do a better job than 10,000 doctors. It's entirely possible she can, right? Whether this should be a medicalized issue or whether it's best done at a more public health, I think that's a very open question.
Elliott, last word?
I mean, if you look at the interventions that are more likely to be successful, I believe they're not going to come from the doctors. They're going to come from community-based interventions.
Yeah,
that'll get people eating healthier earlier in their lives.
We didn't change the whole smoking thing by docs in the office. We changed it by a whole variety of community interventions. Well, if one good sign of a good panel is that there are a lot of unanswered questions and people who'd like to answer questions, this was a superb panel. Let's thank Gill and Elliott.
Thank you, Dee.